Welcome to this webinar, Spinal Cord Injuries, Cervical versus Lumbar, and Planning for Long-Term Needs, Part 2. This webinar is hosted by Medical and Life Care Consulting Services, case management and nurse consulting firm headquartered in Massachusetts. We're excited that you've joined us for this presentation. My name is Gigi Liggins, and I'm the moderator for this webinar. Post-webinar, we will share a link where you can access an on-demand replay, along with a link to a short survey. Please take a moment to complete the survey. Your feedback is valuable and helps us in the planning of our educational resources. We're excited to host this webinar and look forward to an opportunity to partner with you. To kick us off, I'd like to introduce our speakers. Joining us today is Cynthia Borbo and April Pettengill. Cynthia Borbo is president and founder of Medical and Life Care Consulting Services, often known as MLCC. She's a registered nurse and certified rehabilitation nurse, case manager, a nurse life care planner, and a legal nurse consultant. She has worked as a nursing professional for 40 years and currently leads Medical and Life Care Consulting Services, a practice of professional nurse consultants and case managers who provide medical case management, medical legal services, including life care planning and ancillary professional nurse consulting services. As a nurse life care planner, Cynthia Borbo has completed hundreds of life care plans, life care plan critiques, life care plan projections, and medical cost projections for both plaintiff and defense, insurance companies, and patients throughout the United States and internationally. Cynthia founded MLCC in 2001 and is presently a member of the American Association of Nurse Life Care Planners and is a board member on the CNLCP Certification Board. She is also an active member of the Association of Rehabilitation Nurses and the Case Management Society of America. Also with us today, April Pettengill. April Pettengill has over 34 years of experience as a registered nurse. She worked in the hospital setting in geriatrics, pediatrics, telemetry, and orthopedics. For the last 31 years, she has been a case manager for work-related injuries and illnesses. Ms. Pettengill has extensive experience with catastrophic injuries, and in 2004, she became certified as a nurse life care planner. In 2005, she expanded her areas of expertise by attaining the Medicare Set-Aside Consultant certification and has been writing MSAs ever since. April has been a member of AANLCP since 2004, actively working on the conference committee and most recently as secretary on the CNLCP certification board from 2007 to 2018. For this webinar, the objectives are that the viewers will get a brief overview of the abilities and deficits at various levels of spinal cord injury, as well as attain a basic understanding of the long-term requirements for care and equipment with various levels of spinal cord injury. At this time, I'm going to pass it over to Cynthia Borbo.
Thank you so much. Thank you all for joining us again today. I'm hoping that most of you attended part 1 for spinal cord injuries. There was a lot of information that we included in that talk and talked as fast as we could, but really found that we could talk for days about this topic and care for people with spinal cord injuries. So we're not going to go over all of the anatomy and physiology and the different types of injuries that occur for people with spinal cord injuries. But I am going to go over again the neurological levels and functional potential at each level, just briefly and quickly, so that we can actually get directly into what care needs are identified at each level. So C1 to C3 level, there is limited movement of the head and neck. Breathing can be dependent on a ventilator or an implant to control breathing. With communication, talking is sometimes difficult, very limited, or impossible. Assistive devices could be used, such as a mouse stick for typing on a computer, or an eye gaze technology, such as a Dynavox, can allow someone who cannot speak answer by using their eyes to trigger a response from this device. Assistive device technology can be used to turn pages, use a telephone, and operate lights and appliances in the home. An electric wheelchair can be operated by using head control, a mouth, stick or chin control also. A power tilt or standing wheelchair can be used for independent pressure relief. Total care is needed, but with the ability to communicate, the patient can direct caregivers in their daily activities, bathing, dressing, personal hygiene, transferring, bowel and bladder management, and just everyday life and what they want to do all day. Now, obviously, as we discussed in the past, there are complete and incomplete levels, so types of injuries. So what that patient is able to do is going to be very individual and independent. C4 level, these patients usually have head and neck control, and they may shrug their shoulders. They may initially require a ventilator for breathing, but usually they adjust to breathing full-time without any assistive device. They could have problems with diaphragm issues because of paralysis of part of their diaphragm, and need to do additional pulmonary hygiene, but usually can breathe on room air. Communication is normal, but they can have a weaker voice. And that comes also from the breathlessness that can happen because of that poor lung control. And daily tasks are completed with equipment. Some people may have limited independence with feeding, and they can independently operate an adjustable bed with a controller if it's adapted. C5 level patients have head and neck control. They can shrug their shoulders and have shoulder control. They can bend their elbows and turn their palms face up. They're independent with eating, drinking, face washing, brushing of teeth, face shaving, and hair care with setup. They can do self-assist coughs and pressure relief by leaning forward or side to side. They may have strength to push a manual wheelchair for short distances or over smooth surfaces. A power wheelchair with hand controls is used for daily activities. And driving may be possible as long as there's no cognitive problems that have occurred because of the injury. Oftentimes, an injury can include multiple body parts, obviously, not just the spine. But once a driving eval is completed, if they have enough control, they're able to drive. C6 level patients have movement in the head, neck, shoulders, arms, and wrists. They can shrug their shoulders, turn their palms up and down, and extend their wrists. And all of that is key for an increase in their ability to be independent. With special equipment, the patient can feed himself, bathe, groom, do personal hygiene and dressing, and may independently perform light housekeeping activities. They're independent with pressure relief and skin checks and turning in bed, which is key for some of that independence and being alone. Some patients can do independent transfers, but often require a sliding board. And a manual wheelchair may be used for daily activities, but power wheelchairs are used for greater independence and out in the community, any distance. C7 level injuries, the patients have similar movements as an individual with a C6, but they have the ability to straighten their elbows. They're able to perform household duties and need fewer adaptive aids. They're able to do wheelchair push-ups for pressure release, and they use a manual wheelchair, and they can transfer easier. And C8 to T1 level. Patients here have added strength and precision of their fingers that results in limited or natural hand function. They can live independently without assistive devices for feeding, bathing, grooming, oral and facial hygiene, dressing, bladder management, and bowel management. And they use a manual wheelchair, and they can transfer independently. April's going to go on past this level after I'm done. So again, as we discussed the last time, all of these different areas, every body system and function is reviewed and assessed with these patients. And again, that whether it's complete or incomplete injury, whether their psychological status is appropriate, whether if they're having other issues such as substance abuse problems, depression, pain, all of these things affect how people live their everyday lives. So it's important to take each person as an individual and not treat them as just, okay, you're this level, this is what you should be able to do. So many things go into that decision. Next. So quadriplegics. A person with quadriplegia, again, we assess the body, but as nurses, we very much look at, or healthcare professionals, we very much look at each different area that adaptation may be needed to be made in their lives, right? So that can include therapies, future medical treatment, diagnostics, durable medical equipment, medications, home care services, facility care, transportation, architectural changes to their home because of the level of their injury, orthotics and prosthetics, surgical and medical procedures, and hospitalizations also from complications that occur due to their injury. Next page, excuse me. So projected therapeutic modalities, as life care planners and as nurses, we're used to looking into all areas that patients need help. We do a nursing diagnosis, we determine where their areas of impairment are, and then set up treatment accordingly. So some of the therapies that occur would be physical therapy, occupational therapy, speech therapy, feeding therapy, respiratory therapy, vision therapy, assistive technologies for all their adaptive communication equipment, driving evaluations and training, acupuncture treatment, chiropractic, and massage therapy. So how do you know which ones you're going to use for your patient? So I think that most patients that are quadriplegics, or most patients that have any kind of spinal cord injury, there's a period of time where you maximize the benefit of therapies. And so for a good 18 months after the injury, focus is on gaining as much function as possible. So physical, occupational therapy, speech therapy, feeding therapy for children, those are all very much should be intensive during that time period, trying to achieve maximum independence and quality of life for that patient. And then as they reach their maximum medical improvement and get to the point where they're the best they can be and they're doing everything that they can do, at that point, then therapy is more of a maintenance type therapy. So oftentimes with quadriplegic who are being managed in the home and even in a facility, range of motion is done 1 to 2 times a day. And it can include a repetition of their exercise program like they had in the past. So in other words, if they did a UBE, an upper extremity bike in the facility, it's great to get one at home so that they can continue to do those things. Pulleys, upper extremity exercise equipment where their arms are supported. All of these can be purchased for the home and the patient can do those exercises. If you stop doing the exercises, very often patients will lose that skill. So in other words, if they're not, as a quadriplegic, let's say they've achieved the ability to sit on the edge of a mat and balance, or even kick with their legs, because if they're an incomplete injury, they could possibly do that. If you don't keep doing it, then those muscles get weak again. So there's a fine balance between doing some exercises and getting the right supportive equipment. You don't want to get them to be too supported, because then they could lose that core strength that they might have been that they did gain immediately post the injury. But if you don't use it, you lose it. And the same occurs with these patients. So depending on their respiratory status, if they have a partially paralyzed diaphragm, if they have a good cough, whether they have sleep apnea or not, all of these things have to be taken into consideration. Good sleep promotes healing of the brain, healing of the body. And if they don't have good sleep, then they can evolve into being depressed, being fatigued all day long, and having increased complications. Vision therapy can happen with patients. Again, every injury is not usually just a very simple, this is the one level that was injured. There's often multiple injuries that can happen. And so oftentimes you could have a head injury along with a spinal cord injury that may have affected visual fields. So all of these things have to be taken into consideration. Assisted technologies is also very important. So if you have someone who has a head injury and a spinal cord injury, and they need this technology to communicate with their environment, it's important to continue that. I haven't really been telling you too much about how frequently to do it, but with physical therapy, occupational therapy, and speech therapy, I do feel that depending on whether they have swallowing problems or any of those kind of communication things, therapy for whichever part of the injury is necessary, periodically needs to be done throughout their lifetime. And I have seen that patients typically every few years start developing new problems, whether it be a shoulder stiffness and pain, or another joint issue. They may lose the ability to bathe and dress, not bathe and dress, but brush their teeth or shave where they could do it before. And all these things are important for self-worth. So periodic physical therapy and occupational therapy is anticipated to be needed throughout their lifetime. And I have my own practice where I see patients frequently in this condition, so I'm comfortable with the time frame that I've identified as being a repetitive need throughout their lifetime. But every patient is individual, and so you have to determine that when you're doing your life care plan. Driving evaluations and training also, if a patient is capable of doing that, is great for independence. That doesn't mean that they don't need an aid to assist them, but it's nice for them to be able to have the independence that they need to be able to get into a car by themselves and get behind the wheel and do what they need to do. Acupuncture treatment is often used for swelling issues and also pain management, and that may be needed intermittently throughout their lifetime. The same as chiropractic and massage therapy. These are more palliative type of treatments in place rather than restoring function, but very important when someone's dealing with pain. Next. Future medical treatment is very much based on the areas that are affected. So with a quadriplegic, depending on the level, you will see certain things being needed on a regular basis annually. So if a patient has swallowing problems because they're a high level, and also nutritional issues because they're not eating enough to either sustain their weight or they're eating too much. We often see nutrition being included in a life care plan and in care of these patients. The primary care physician is the gatekeeper for all treatment for the most part, along with a physiatrist. And oftentimes I see patients being seen at an increased number of visits per year because they're the gatekeeper. And so when the problem occurs, it's immediately we contact the primary care physician for those referrals that are needed. Neuropsychology, when you have some either head injury issues that are occurring, or oftentimes even just with a spinal cord injury, A patient may be depressed or having memory issues because of medications they're on. And neuropsychology really helps define where the problem is coming from. And so I often see patients years after an injury still getting a neuropsych eval periodically because something's going on and we can't quite figure out what it is. So we want to know if it's emotional or if it's something metabolic. So both areas are evaluated. Obviously, with a quadriplegic, you're going to have some kind of neurogenic bowel and bladder. So urology is very important for managing that. Oftentimes, a urologist will do both the bowel and bladder function, not just the bladder, and manage all of that, unless there's some significant issues with it, at which time then you would go to a gastroenterologist. A urologist is regularly seen at least annually, and then PRN for any problems. People have either a suprapubic catheter or an indwelling Foley catheter, or even just repeat urine infections. Over time, there's a system that's developed, and so caregivers are trained to be able to, or family members are trained to be able to take a urine specimen when there's a problem, calling the urologist and getting an order for that so that it can be tested and then treatment put in place if needed. But a urologist will see them regularly for evaluation of their kidneys and their bladder. Nutritionists we talked about. Obviously, if a patient is putting on too much weight, that's not good for the weight-bearing issues and skin issues, skin integrity. But also, any kind of oral motor issues that may occur because of a concurrent problem. Psychiatry is very important, and for most patients with any kind of spinal cord injury, it's important that periodic evaluations are completed throughout their lifetime. Oftentimes, these patients are on antidepressants or mood stabilizers of some kind, or even need assistance with sleeping at night and dealing with anxiety. So both psychiatry and psychology are important. People do not want to go and be seeing physicians and treaters every day. That's not what life's about. So the focus is on finding the right balance. Most psychiatrists recommend counseling along with the medication management. And while it's being beneficial, then it's important that that's in place. But oftentimes when there are times of severe stress or when something in life, in normal life, highlights their disabilities and their inability to work with or live with their family or interact with their friends, all of that can cause a lot of emotional distress. So periodically they may need counseling to assist with those kind of transitions. Ophthalmology is also necessary when there's additional issues going on, concurrent diagnoses, and an otolaryngologist, ear, nose, and throat doctor to evaluate for any problems that are noted in that way, whether it's the impaired speech because they're breathless or their speech is very faint and they don't have a strong voice. All of these things are looked at by an ENT. Audiology can be important if there's concurrent diagnoses. We've got to look at the whole person. If they're impaired in one way, we want to make sure that all the other systems are working very well. Obviously, a neurologist is involved if there are any ongoing neurological issues such as seizures that occurred because of the injury or any other changes in their status. Podiatry is important. That is done regularly 4 times a year for most patients. If it's not taken care of with the proper shoes, the right compression garments, you can have repeat infections that occur. So nails may need to be removed or whatever. And so those are always included in the plan and used. Physiatry obviously is the number one physician group that I feel addresses most of these spinal cord injuries in these patients long-term. Their expertise is in obviously maximum medical improvement and independence, but also looking at the whole person and making sure that spasm, tone are addressed appropriately. So a physiatrist would do that. And really, most quadriplegics would see the physiatrist 4 times a year at a minimum, in addition to the other things that are done. An orthopedist may be needed because of pain in joints that occur, contractures that occur, and those types of issues. Oftentimes also, if there is a fall that occurs, we can have fractures because of non-weight bearing status and brittle bones. Next page, please. Now, diagnostic testing and lab work obviously is based on what is going on with that individual patient, but often I see regularly calcium, magnesium, CBC with diff, and metabolic panel done with regularly twice a year, in addition to any healthy blood work that would be done for health maintenance. For urine infections or the bladder, we would do a urinalysis, a urine for culture and sensitivity. Every patient is different, so it depends on what they have. I personally find suprapubic catheters to be the best managed, and if you have good training of the caregivers and a protocol in place for cleaning all the equipment regularly and just maintaining hydration and all of those things that go into it, I feel that you can really keep a patient healthy. Frequent urine infections are not good, and they affect the whole body long-term. Urinalysis and urine for CNS is done frequently. Cystoscopies are done every 3 to 5 years, as well as possibly even urodynamic testing if there's any change. Sometimes you'll see where patients will have urine that will try to come out the old way through the ureter, or through the penis, the vagina. Sometimes people have urodynamic testing that is completed, and that's every 3 to 5 years. It can be done because urine tries to escape and not come out through a suprapubic catheter, but will go the normal pathway. And so the testing is done to see if there's something that's changed in regards to the sphincters and the muscle tone in the bladder and the whole urodynamic system. Bladder and kidney ultrasounds are done on a yearly basis to make sure that the patient is not having any backup of urine into the kidneys regularly, and that there's no other problems that are going on in the kidneys. Additional radiological or neurological testing that could be done would be an EMG. If there's a change in numbness and tingling, EMGs are often used along with Botox injections. So you'll see them being done regularly on patients 4 times a year with Botox injections. Spine films, CTs of the spine, MRIs of the spine. Bone density testing is also done periodically to make sure that the bones are not brittle to the point where we could be having a spontaneous fracture. X-rays of bilateral shoulders, elbows, or even a shoulder MRI would be needed with increasing pain. Obviously, any patient who has any form of spinal cord injury, it's really traumatic to have a rotator cuff repair or some type of surgery to the shoulders where you're not going to be weight bearing for a period of time. Patients then need to be immobilized. If they had any ability to be able to, let's say they're a paraplegic and needed to be able to transfer themselves, it just affects the whole system. And if they're a paraplegic, then obviously they need 24-hour care during that time because they're not able to use their arms like they normally would to be able to transfer themselves. Quadriplegic, you have to be more careful with transferring the patient and immobilizing it because you want that rotator cuff to repair. And really, a lot of any treatment that would be done would only be done for pain management at that point. It wouldn't be for improving function, but some people have severe pain in their shoulders because of immobility or adhesions, scar tissue that develops. Sleep studies are important to be done because obviously, if you're not getting enough oxygen at night, then either a CPAP, a BiPAP needs to be put in place, or even just oxygen. And that can be done both inpatient or at home. More and more, I'm seeing more home testing being done. Chest x-rays also for any kind of respiratory problem that develops. And really keeping patients away from sick caregivers is important. So that's a big thing that we watch for. KUBs of the abdomen, CAT scan of the abdomen, all to determine if there's maybe a blockage or obstruction. A really good bowel program is really important. And if you've got a patient who's not having a bowel movement every 7 days, that could be life-threatening. So testing is done for that also. Colonoscopies are important for all of us, but they're also important to see if there's been any anatomical change because of the difference in the nerves and how they're working the body. Upper GIs are also done for any, stomach complaints or pain issues. And we want to make sure that the motility of the whole GI tract is good. So durable medical equipment. I separated into the areas that obviously they are listed for hygiene ADLs. We use obviously gloves, handheld shower head, tilt and space shower chairs for quadriplegics is important in case they have any problems with autonomic dysreflexia, and also just comfort and unseating because it can take a while to get a patient through the whole bowel and bladder and showering process. And so they're up for a long period of time, and straight up can cause a problem for some patients. And the shower chair is oftentimes used over the toilet so that the bowel program can be done. There are shower chair ROHO cushions which are available, which I highly recommend. I've had patients have shearing injuries to their skin because of the normal cushion on the shower chair. Obviously, when you have caregivers in the home, there's going to be an increased need for hand soap and paper towels so that people are really being very hygienic when they're with everything that they're doing with this patient. In regards to skin integrity, we use a fully electric bed. Obviously, when people come out of the hospital, they have a hospital bed that they come home with, and that's great that they come home to. But over time, people want to live like as normal a life as possible. So I see other types of fully electric beds being utilized with special mattresses. Initially, when they come home, they're always using a low pressure air mattress. However, Tempur-Pedic mattresses also work well if someone is not having skin breakdown issues. Also, the low pressure air mattresses make a lot of noise, so we have to be cognizant of that. It's keeping people up at night over time, and oftentimes they get rid of those mattresses because of that. I always recommend an over the bed table when people are brought home, just because it just makes things cleaner when you're doing treatments, and so they're helpful. Cloth bed pads, disposable chucks, barrier cream. They may need dressing material for wounds, even for protection. With severe wounds, when people come out of the hospital after a time in an intensive care unit for a month or whatever time it is, or just being in the hospital and impaired movement, They come out with often large decubiti that take time to heal, and so wound vacs are often used in the home. Skin protective dressings. The list could go on and on for whatever the care is for a break in skin integrity. Vascular-wise, some patients have trouble with immediately after the injury sitting up and being able to tolerate it. So abdominal binders and compression stockings are used, and some people even have that problem long term. And so oftentimes we do continue to use compression stockings and occasionally abdominal binder. So in addition to maintain health, always supply a blood pressure cuff, thermometer, and pulse oximeter in the home for these patients. Respiratory wise, as I said before, you could use a CPAP, BiPAP. Patients can come home on a vent with all the vent equipment that's needed for that. Ambu bags, trach and trach equipment, oxygen and tubing with mask, humidification of the oxygen, or even just humidification in the room, a suction machine, suction catheters, Yanker catheters, suction canisters and tubing, and the list goes on and on, depending on how impaired they are and what kind of problems. I see more and more children with respiratory problems that need a lot of equipment like this, but it also occurs with adults, obviously. So mobility-wise, again, is dependent on the level and what they're capable of doing. A lot of patients with very high-level injuries are using a sip and puff chair, wheelchair controls, or a chin or head controls. But I've even had patients that are C4 or 5 injuries that have needed to use chin or head controls in a motorized chair. Because they get themselves in one position and then they can't get themselves out of that position. So if they're laying flat back and their aide is not in the room with them and they want to be able to get themselves up, sometimes they can't do that because their arm just won't stretch that far. So we use head controls for those. So a motorized wheelchair is great with standing capability. It's great for the legs and for circulation, for the gut, and to get everything working as normally as possible. You have to also include power chair maintenance. We always have a manual custom wheelchair made for these patients so that if their wheelchair stops because either the battery goes dead or something malfunctions, and it does happen, you need some way to be able to get that patient back to their bed. So they might be outside when this is happening. And so you'd have to bring a Hoyer lift outside and lift them to this manual wheelchair. And manual chair maintenance, Rojo cushions for the chairs, a Hoyer lift. Hoyer lift maintenance is used, and Hoyer lift slings are needed periodically every couple of years. Hoyer lifts obviously are replaced every 5 years, so I usually get 1 or 2 slings in between that time. I always include a backpack with supplies for the wheelchair. There are a lot of things that you obviously need to bring if someone is self-cathing. Obviously, you need to bring all those supplies with you, and there's just potential for other complications for happening when you're out and about. So that keeps everything there. I also, when we're taking care of these patients, always have a binder that goes in the backpack that is a history of what's been going on with the patient. So if there's an emergency that happens when they're out and about, they have their history with them. A stander is good and should be used on a daily basis. A UBE. E-stim is used for hand motion and also for pain management. Ceiling lifts are absolutely great. And if the patient is living somewhere where that can be installed and the ceiling is, the ceiling joists are going in the right direction, a ceiling lift is easier to use and less prone to having injury from it than a Hoyer lift. You need to replace the ceiling lift motor every couple of years and obviously need maintenance on that ceiling lift. If a patient is a lower level and can transfer, then obviously a transfer board or a BZ board can be provided, a rolling walker, etc. There are some patients that are incomplete injuries that are able to bear weight on their legs and use a sliding board to transfer, depending on the level. and they're still considered quadriplegics, but they're able to do a little bit more. So they need more of the manual equipment for ambulation. Next. Communication devices could be a very simple device, or it could be a complex device like a Dynavox, and with eye gaze. Computers, tablets, we use Siri or Alexa to control lights and TVs in rooms for these patients. Earbuds are also helpful. Pandora will open emails. And there are universal cuffs and assistive touch on phones, etc., depending on the level of function. You know, you may have somebody that has Brown Secord, and so they're able to ambulate with someone. They can't use their arms, and so they have to use their body, their body core strength to ambulate. Every single patient is different, and you just need to take that into consideration when you're designing your life care plan or caring for these patients. Urinary wise, could be catheters, suprapubic catheters, leg bags, leg secures, bedside bags, irrigation kits, catheterization kits, 60 cc syringes, 10 cc syringes, vinegar. We use vinegar and water, soap and water to clean out the bags every night to prevent, contamination when it's used again. Normal saline for flushes, Remicedin for flushes, whatever is needed depending on the patient's problems. But if you have an aggressive program where you're cleaning everything and making sure that it stays intact and a closed system as much as possible, the urinary infections are much less. So catheters are changed once a month. Leg secures are changed twice a month. Maybe more frequently. Every patient's different. Bedside bags and leg bags are changed every 1 to 2 weeks, and they're cleaned every night and switched out. Irrigation kits are used once a month. Catheterization kits once a month. 60 cc syringes once a month. 10 cc syringes once a month. That's for the catheter change. Vinegar, a big gallon jug of vinegar every month for vinegar and water rinses of the tubing and the bags. Normal saline for flushing, and then the Remicedin for flushing, or acetic acid is usually a prescription, but you can make a homemade if the doctor orders it. Bowel programs, Ducalox suppositories, Magic, bullets, lubricant, Fleet's enemas, soap suds enemas are needed. A daily bowel program is necessary. You don't want anybody going more than a couple days without having a regular bowel movement. GI needs might be a G-tube, a Mickey button, feeding pump tubing, IV poles. All those are changed. The feeding pump tubing, and the IV pole are changed every 5 years. 60C syringes, tubing dressings to put around the G-tube to protect the skin. It's a personal preference. Some patients like it, some just leave it open to the air. Tape. Oftentimes patients need diverting colostomies because of wounds. So colostomy bags, wafers, skin prep, and irrigation kits. Next. So home care services is always a big topic. Case management occurs on a monthly basis. We need home health aides to take care of quadriplegics. I actually have had a patient with quadriplegia that actually had 4 hours by himself during the day. He ran a business and was comfortable being alone, and just had communication ability to emergency services if he needed it. But most people with quadriplegia need 24-hour care. There are awake aids and sleep aids. So if a patient has a level where he's able to turn himself fairly well, he may be independent at nighttime, but he's got to be able to get himself in and out of bed. And that's usually the need for the aids in the event of an emergency. So there are some aids that just waken to calls. They're there with the patient, but are able to sleep, and that's usually at a little bit of a less rate than full awake aid. There are live-in aides that can be hired, aides that come in per shift. I usually recommend that people use a company because, if somebody calls out sick, you can't leave them alone. They need care. So oftentimes families hire patient caregivers themselves. And so there are companies that have employer services that do the employer services for pay and benefits for private hire. Some patients just need a companion, somebody in the house to call when they need help with something. Skilled nursing, RN, LPN services can also be needed, whether it be for the catheter change, for a monthly assessment, for setting up medications for the month or the week, depending on the situation, in addition to a homemaker. So home health aides usually clean the area where the patient is primarily residing. That can be a bedroom, a sitting room right outside that area, and their bathroom. They don't usually clean the rest of the house, although most of them are pretty good and try to help out if they have time. However, most of the time you need a separate homemaker to come in and do cleaning, especially like spring and fall cleaning. Oftentimes I have patients and their homes are just in such disarray because no one's cleaned it for years. And you really, when you start out with those patients, you need to get everything in order and get cleaning in place. There's also yard maintenance, snow management, respite care. If family are going to be gone, if a patient has children who are under a certain age and not in school, you may need nanny services to assist. That's about it. I'm not going to tell you specific amounts because every patient and situation is individual, but we all know what it takes to take care of someone in the home as nurses. So facility care, sometimes it's not possible because of the level of medical issues that are occurring. So facility care is needed, and that can be in a group home, a residential home. A residential home can be with 4 or 5 patients who have similar type problems. Group homes can be larger. It could be assisted living with or without services, a home health aide, an RN for medication oversight, and a long-term care facility could also be used. Depends on what's available in that patient's area. Transportation. These patients all need transportation to get to and from doctor's appointments. So a conversion done to a van is needed. If that patient will be able to drive, van conversion with hand controls. Otherwise, their aides will drive them. And you need to have them be put on the van owner's insurance. Transportation to and from appointments can be short-term or lifetime. And also there's public transportation that's available. Next. Architectural modifications are very specific to each household, or if they're living in an apartment, it's got to be an accessible either apartment or a home. So either accessible with ramps or an elevator. Oftentimes you have to put in an accessible bathroom, so it's a roll-in shower, widened doorways and hallways, an accessible kitchen. If a patient is a lower level and has use of their arms, you want them to be able to roll in under the sink and be able to have the countertops and the cooking equipment lowered. Ceiling lifts are great when patients are a higher level injury because transferring is so much easier and you're able to get them up higher and into proper positioning better. Oftentimes when you are going into a home, there's not room for a ramp, so you have to do an external lift for wheelchair entry. Or if you're going from one floor to another and the family's been there a long time and there's room for an interior elevator, then that is also a possibility. We talked about ramps. Grab bars are needed in the bathroom, whether it be for someone who is a low-level quadriplegic or just even to help the caregivers with care. If patients are hardly functioning, there are voice-activated door openers, which would be great to be able to get that patient in and out of the home. The patient I spoke about was able to get himself out of his home independently, and that's why he could be left alone. A whole house generator is needed, Lifeline, or an Apple Android if it's a higher functioning patient with fall alerts. And then sometimes you have to put additions on homes because the existing home just cannot accommodate the changes that are needed. And that would be a bedroom, an accessible bathroom, room for more equipment and aids for 24-hour care. There are also small additions that you can rent now that are available out there. And sometimes that's a temporary solution, but it can also be a permanent solution. They can build it permanent. Usually when an addition is needed, I usually put on a 20 by 20 or a 24 by 24 addition for my patients. And that seems to work out well and give them the right amount of space. Next. Orthotics and prosthetics. These are all the different types of orthotics and prosthetics can be needed. You want to keep that patient in good position. You don't want them to be contracted so bad that generates pain and other complications such as breaks in skin. So equipment is important. I've listed these here. I'm talking too much, so let's just go to the last section, I think, and then let April get started. So surgical and medical procedures that can happen. So patients that are quadriplegia can have spasm, need a baclofen pump. So there's a trial and insertion and then pump revisions every 7 years. Baclofen pump refills, which can be anywhere from every 2 months to every 4 months per year. Botox injections, which are 4 times a year, 2 to 4 times a year if they're effective. Suprapubic catheter placement and revision is needed in the event that either there's a problem with the stoma, sometimes it needs to be made larger, so you have to take into account that. Hemorrhoid banding or surgery because of a bowel program and the development of hemorrhoids because of constipation. Colostomy revisions. And then obviously we want to get the maximum function, and that usually happens soon after the injury, within a couple of years. So if we can get a hand motion back that they didn't have from a nerve transposition or a tendon transfer, though, that would be great to do so that that person could then use their hand. You know, it's usually a very focused surgery to accomplish something, greater independence. Fusion of the wrist can also occur. Peg placement and revision, and suprapubic catheters are changed by the nurse in the home, in the office, or in the ER if there's no one available. And they can also be changed with fluoroscopy. Hospitalizations, you always have to include, and I pretty much go by the patient's health history and how many types of hospitalizations they've had in the time period since their injury. So it can be an ER visit, short-term hospital stay 3 to 5 days, or extended hospitalization for 7 to 10 days. And that's very dependent on the patient's history. And now I'm going to turn it over to April.
Thank you. So even though Cindy talked a lot about a lot of stuff, you're going to find that people with the lower level neurological injuries are going to require much of the same types of interventions, diagnostic work, equipment, that type of thing. So the only difference is as you move down the spine, you become more functional. So when you start getting into the thoracic T1 through T5, now you have better trunk control, which allows them to be more functional. And usually they don't have to have a power chair at this point. They can go right to the manual chair. And, you know, as Cindy mentioned, they can learn to drive a car with modifications. Sometimes they still have to be in their wheelchair while they drive. In other cases, as they get lower and, you know, toward T4, T5, they can actually transfer out of the wheelchair and into the driver's seat. Some people, if they have incomplete T-level injuries can start to walk with braces and crutches or a rolling walker. So those types of things have to be replaced on a regular basis. Usually you look at crutches about every 5 years, braces every 2 years, or more frequently if they, tend to wear out or they have more moving parts. As she mentioned with the cervical injuries, bowel and bladder still becomes a problem with the thoracic levels. And sometimes, they require enemas and that type of thing to do their bowel program. If the person has a cystoscopy where they have a tube put in through their abdomen into their colon, they can actually perform their own enemas, their own soap suds enemas, which allows them to be, again, more independent. They're more independent with their activities of daily living, such as, bathing, showering. You can do these things with a roll-in walker, with a roll-in shower, which again is a home modification that you need to be looking at. And once you get the person into the shower, you have to have your handheld shower. You have to have things like long-handled sponges and things to get in between the toes and the back and that type of stuff. So those kinds of equipment, I recommend being replaced on a yearly basis, just because they do tend to wear out. So again, as we're getting lower down the spine, you think of your T6 through T8 as working your chest muscles, and your abdominal muscles. T9 through 12 are the lower abdominal muscles, which again gives you more stability and more abilities. So this is what we consider kind of a true paraplegia type level. They have pretty much normal upper body functions. You don't have to worry so much about communication issues or speech issues. Now they're past the diaphragm, so they tend to not have problems with breathing or speech, which is a huge benefit. They can cough without any problems, so you're not looking at the potential for pneumonia to develop. And again, we've got a good ability to control the trunk, so walking now becomes much more of a possibility. If they are complete, so they have no sensory and no motor abilities below these levels, they may not be able to walk even with a lower thoracic injury. If they're incomplete, they usually can do some mobility on their feet. You're still going to have little or no bowel and bladder control, or you might have a little depending if you're incomplete or not. But again, you've got to remember all of those equipments that you need, such as suprapubic catheters or self-catheterization now is pretty much guaranteed, because they have, again, full abilities of their upper extremities. If they need a wheelchair for longer distances in the community, it's going to be a manual wheelchair. And as Cindy noted, once you start using your arms for your primary mode of mobility, you tend to have problems with upper extremities, carpal tunnel syndrome. You have problems with rotator cuff injuries. One of the things that she didn't mention but becomes a problem could be heterotrophic ossification, where you develop bone pieces that grow on your elbows and they have to be surgically removed. Anytime you have somebody that is a quad or a paraplegic, and they have a surgery, as she mentioned, you have to plan for 24-hour care during that recovery period. they can still, they're driving the car with their modification, and as I mentioned, the walking. One thing I do want to mention here at this level is they may start to have some sexual function at this level, but they may have problems such as inability to hold an erection, or they have retrograde ejaculation. So you want to plan for a good urological assessment to be able to manage those things. It could be just a matter of putting them on medication, or they may need to have equipment to help them with their sexual function. For females, pregnancy can be an option, and it is an option, and they have to, again, plan for very specialized OBGYN care during that pregnancy. It's much more frequent. They have to be closely monitored to make sure that they're not having any issues with autonomic dysreflexia, that the babies are developing appropriately, that there's no complications or anything like that. So when you're putting together the plan, make sure that you're considering all of these options as well. Okay, next slide. When we start getting into the lumbar area, the spinal cord actually ends in the high areas of the spinal cord, and then below it, it becomes just a bundle of nerves. And so you can still have some function and some feeling, even if you have some, a more complete type of spinal cord injury. You still may have problems with bowels and bladders, but it might be easier to manage at this point. You may not have to have an enemas. You may be able to manage it with an oral medication such as Senna or Miralax or something like that. Their strength in their legs become stronger, and walking is more of a possibility. Standing is definitely a possibility, but they're still going to get tired, and they're still going to need support. So I recommend putting in a manual wheelchair for long distance community. Braces still might be needed because of foot drop or inability to flex the feet. They should be totally independent with grooming, bathing, but they may still require equipment. And for me, for safety purposes, I pretty much always put in a shower chair, grab bars, and a handheld shower, even with the lumbar levels of spinal cord injury. Home maintenance, they should be able to do pretty well, but you're going to want to include home care that is for the deeper kinds of home maintenance things, like dusting the tops of their cabinets, and getting into their bathtub might be a challenge for them. So, all right, next slide. The medical treatment, as Cindy mentioned earlier, you're going to see all of these types of things. If they have a breakdown in their skin, you're going to want to also include wound care specialist, and perhaps even general surgery if it's really a deep skin breakdown, because that's the person who's going to be doing skin flaps, debridements, that type of thing. Therapies, again, we're talking, the same that that Cindy had mentioned earlier. I would add on to that also recreation therapy, especially when you start getting in the thoracic and lumbar levels. You can have somebody doing adaptive kayaking or skiing or bowling, or I had one gentleman who had a low thoracic, and he was doing adaptive rock climbing. So many things are available these days, great supportive programs. There usually is a cost to them. or a quote unquote donation that is recommended, and I put the cost of that in the plan so that the person can participate in these programs. So she went through all of these equipment needs, for dressing equipment. You've got zipper pulls, button hooks. No tie shoelaces are huge. I can't tell you how many people who have spinal cord injuries who say, I just can't tie my shoes, or I don't want to wear slip-on shoes for the rest of my life. So that's something to think about. They actually have some great, really nice looking shoes that don't tie, but they look like they're tied. And actually, if they have braces, there's a shoe company called Billy Shoes, and it has a zipper on the side of the shoe, and they have both athletic type shoes and dress shoes. It has more room to be able to put the brace in the shoe, and then you just zip it up on the side, and it looks really great. Things to think about also are different types of cooking equipment that might be beneficial to them, especially if they have limits in their upper extremities. You can see those listed there. I don't need to go through that. One thing you may want to also consider with anybody who's got bowel and bladder issues, even though they're on a regular program, you may want to consider diapers or overnight briefs for them. I think that Cindy hit on most of these home modifications. The one that I would add that would be appropriate for the thoracic and lumbar levels is a washer and dryer with front loading access, or now they have some that are what they call all-in-ones. So you put the clothes in, and it's a washer and a dryer all in one. When you're looking at home modifications, one of the things you want to think about is making sure that all of the light switches are at wheelchair level, that the door handles are lever types and not turns. I think that she mentioned most of these. So let's see, next slide. Again, surgeries, she talked about those. And the surgery that I was mentioning for the self-enemas is called ACE procedure. So that's another one that you can think about when you're looking at potential surgeries or complications in your life care plans. I think we talked about most of these. And so if you're thinking about complications in the plan, I tend not to put all of the costs of the complications in the plan. I would potentially put them in if I thought it was something that I would really expect, like a urinary tract infection, hemorrhoids, those types of things that you pretty much can be guaranteed that you're going to see with people who have spinal cord injuries.
All right. Thank you very much to Cynthia and April for sharing so much information on this topic. To those who've taken the time to watch this webinar, thank you. We will ask that if you have questions that you always consider reaching out directly to Medical and Life Care Consulting. Our consultations are always complimentary. You can also visit our website to learn more about all of the varying services we provide, including comprehensive life care plans, life care plan projections and medical cost projections, medical chart reviews and chronologies, Medicare set-aside allocations, focused estimates of care, and legal nurse consulting. Again, thank you for joining us today. Have a great day. Okay, that's it. So we're going to end it. We're going to go back and listen. We're going to create what we call some aha moments to kind of overlay on the slides, just because we get to be a little bit more fancy because we're not recording these live. And we will work on all of that post-production over the next week so that we can publish it and then start all of the email campaigns from the 6th out for 4 weeks.
Gigi, did you see I
Yes.
paused once?
I did on slide 14. I caught
Okay,
you.
great. Sorry.
Thank you. No, I have it.
Like,
That's why it was there.
Oh my God, my
Um,
mouth would it was just coming out all wrong. I was like, oh my God.
No, you did perfect. I wrote it down. It was slide 14 about urodynamic testing. So we'll find it, break it, clean it up,
Thank you.
and it'll be gone.
Thank you.
All right, thank you. Happy Friday. As soon as we
Thank
get
you.
the post video, I'll send it to you so you can watch it.
Thank you.
That sounds great.
All right.
Thanks.
Thank